Hello, this is Nick Tonbuto, and I want to welcome you to this lecture on acute abdomen. So, my name's, like you can see on the screen, Nick Tonbuto. I am a clinical officer and I teach in the Department of Clinical Medicine and Surgery. And here I want to take us through acute abdomen. So let's see what's there for us. So as an introduction, we are going to define acute abdomen, and by definition, it is a severe non-traumatic abdominal pain with a very short onset of time. Usually the pain, when you get the patient, they'll have a history of severe abdominal pain that started less than 24 hours ago. So if that is the complaint, then it fits for us to say this is an acute abdomen. And acute abdomen has a wide range of causes. Like we've said, it's severe abdominal pain, and this pain could come from so many conditions, and if by classification, this is going to range from surgical conditions. Examples are intestinal obstruction, appendicitis, volvulus, and such like conditions, or it can be from an obstetric cause. For example, somebody has got a ruptured ectopic pregnancy, then it can cause such severe abdominal pain within a very short duration of time. Medical conditions also could cause severe acute onset of abdominal pain, and things like, let's say, a patient comes with acute pancreatitis, then they are going to have severe abdominal pain, you see. So all these things, by classification, the conditions can fall in all these categories. Yeah, and if we go deeper into these categories, you'll find that surgical causes make up the majority of causes of acute abdomen, and they are going to include, like I said, intestinal obstruction, appendicitis, intussusception, volvulus, perforated peptic ulcer disease. Of course, peptic ulcer is a medical condition, but once there is perforation, we say there's a complication there, and the management, because it is surgical, then it falls under the surgical cases. Then you're going to have peritonitis, that condition where the peritoneum is inflamed. It's going to cause a lot of pain, and we've got intra-abdominal and hepatic abscesses. Also, these are causes of acute onset of abdominal pain. If we go and look at the obstetrics and gynecological causes, we have, like I said, ruptured ectopic pregnancy. The moment that pregnancy ruptures, then you've got acute abdominal pain, and usually it's quite severe, and therefore that causes acute abdomen. Twisted ovarian follicular cysts, these are going to give you a lot of pain as well, and therefore can cause acute abdomen. That is pelvic inflammatory diseases. You've got endometriosis, dysmenorrhea. Dysmenorrhea can sound a bit easy, but there are some ladies who can experience very severe forms of dysmenorrhea, and they are going to, the pain is going to be acute on onset, and again, that is a cause of an acute abdomen. You've got acute salpingitis when the uterine tubes are inflamed. That as well gives you severe pain with an acute onset. So all these are again causes of acute abdomen. And if you look at the medical cases, you've got acute gastritis. This is going to give you a burning pain, a lot of pain acutely, and therefore acute abdomen. Pancreatitis, cholangitis, inflammation of these organs, inflammation of the gallbladder, cholecystitis, acute pyelonephritis, renal calculi, all these are going to cause severe abdominal pain with acute onset. Of course, the renal calculi, this is surgical, but sometimes because of the mode of management, then it can be placed under medical. So the question is, how do we approach a patient with an acute severe abdominal pain? Usually the major decision for a clinician is to decide when seeing this patient, the decision is whether you're going to admit this patient maybe for observation or for additional things you want the patient actually to stay or not. Do you need to do some additional investigations or not? Whether you need an early operation or the management can be non-operative. So this is the key decision. Where do you, what management is this patient going to benefit from? And this is a quick decision, a decision that actually has to be made at the time that the clinician is seeing the patient. How do we arrive at this decision? It is by careful examination of the symptoms and physical examination that are very key. And therefore we are going to be able to reach a decision. We do not really reach such a decision by doing the sophisticated investigations that you know of. Usually these are emergencies, and when that patient comes, you need to quickly make that decision. And an evaluation of the symptoms and careful examination, the physical exam, is what we are going to use to be able to quickly make a decision whether we are going to admit the patient, whether we are going to call for investigations, whether we are going to do an early operation, that is surgery, or we do not need to operate this patient. For example, if a patient comes and through the history you are able to notice that actually this patient has got dysmenorrhea, then there you are very confident. You just need to relieve the muscle spasms in the uterus medically, and that patient will be okay. You do not need to admit the patient, you do not need to do investigations, you do not need to operate the patient. You just manage with drugs and that patient is going to be okay. However, for example, from examination, you find each and everything points out to, for example, peritonitis. Then a quick operation is necessary in that patient, because you do not do an operation as early as possible, then the risk of severe other complications is again there, and that is not the way you want to end. So the criteria, how do we examine these symptoms? One, these patients are the main complaint here is abdominal pain. So you need to know the location of the pain. Depending on the location, you can be able to guess, for example, what really is happening with that patient. We are going to go deeper into that. You need to look at the radiation, the spreading or the shift of the pain. Is the pain in one place, or is the pain shifting to another place? Is the pain radiating? Starts here, but then again, maybe it starts here and goes all the way to a certain other place. That will give you an idea of possibilities of what kinds of tissues are there and what tissues are involved there. You are able to have a gist of what is happening and be able to make a decision. The mode of onset and progression of that pain. How exactly did this pain start, and how is it progressing? That is very important, because different conditions will have different modes of onset of the pain. Some of them are going to be kind of insidious. For example, if we have a pain due to an infectious thing, the pain is going to be insidious in onset. But for example, if you have pain due to a ruptured ectopic pregnancy, the pain is going to be kind of abrupt. This minute this patient is okay, and the next minute there is a lot of pain all at once. Then with that you can be able to differentiate. The character of the pain, very important. I think we are also going to go deeper into this, but you need to understand, is the pain burning? Is the pain kind of grinding? Is the pain colicky, as in comes in bouts? That is very important because it helps you understand what kind of tissues or organs are involved. It makes you to be able to make a quick right guess about the pathology that is going on underneath. And then what aggravates the pain and what relieves the pain. These are two very important things, yeah, because different mechanisms of pain are going to have different relieving and aggravating factors. Then you need to also examine for other general symptoms. General symptoms, for example, these are symptoms of that is systemic symptoms. For example, you might want to examine a patient or ask a patient about fever. Because the moment you have an infectious cause, then fever is quite a common presentation. But for most of the other non-infectious causes, then fever is not there. So fever, this is only one, but there are many more. You need to examine all these general symptoms that are going to impact your judgment. And then you screen for risk factors. Yeah. These conditions that you're suspecting, all of them are going to have certain risk factors, and then you need to be able to screen for those risk factors. If the risk factors are positive, then it even adds to your diagnosis. And then specific and non-specific signs. You need to go to physical examination. And when you go to physical examination, there are those things that you're already thinking about. For example, you're thinking about, oh, this patient could be having intestinal obstruction. There are some specific signs that go with intestinal obstruction. So you want to examine and see, are those signs there or not. But after examining those signs, then you need to go to the other non-specific signs and look for them as well. Signs that do not indicate a particular pathology, but it's a general sign. It can be present in a number of them. Then you also need to look for those ones, and based on the history, you can be able to make a decision where really this lies. So if we look at the location of the pain, again, visceral pain versus parietal pain. Visceral pain is usually dull because of the poor, and it is poorly localized because of the innervation. These nerves just kind of come from different tissues, but again they just insert in one place, and the sensation is kind of the whole of that place. So you cannot pinpoint exactly where the pain is. So this is something nice as well, as opposed to parietal pain, where the pain is usually sharp and it is better localized. If the patient tells you exactly with one finger, this is where I have the pain, then that most probably is going to be parietal pain. And when we talk about referred pain, this is where the site of pathology is different from the site where the pain is strongly felt. So again, as you examine your patient, as you ask your patient, you have to keep this in mind so that you are not swayed towards believing that actually the pathology is here when actually you are talking about a referred pain. And this is quite common. For example, patients with gastritis, they are going to have pain referred maybe to the neck, and then you think, this could be torticollis or something, but actually it's gastritis, and then you treat them wrongly. So that's very important. Next, we are going to I'm going to show you